Greetings, hello, and thank you very much for the opportunity to participate in the Clinical Neuroscience Symposium in honor of Dr. Edgar HOUSEPIAN. It's a great privilege to be a part of this conference, and thank you so much to the organizers for the invitation. Today I will be speaking about intracranial recordings, specifically implantation strategies and intraoperative monitoring. Here's a brief outline. So today we'll speak a little bit about the historical overview. It's always very important to see where we've been so that we know where we are going. And then quickly I will talk a little bit about the different methodologies for intracranial recording with a focus on stereo EEG, but I will also speak about subdural grids as well. I'll talk about the surgical workflow of stereo electroencephalography or stereo EEG, and I'll highlight a case example. And finally, I will present on future directions, looking at how are we using this data to guide epilepsy surgery. And this includes a brief overview of artificial intelligence and machine learning. I have no disclosures to make. Now, invasive EEG monitoring refers to the implantation and the recording of intracranial EEG. As we know, nearly 1/3 of patients with epilepsy are refractory to medications, and nearly half, if not more, of these patients are going to benefit from invasive EEG evaluation. The goals, therefore, are to not only lateralize, but also localize the epileptogenic zone, and at the same time, allow us the ability to identify, possibly map, functional or eloquent regions prior to performing the resection. To speak a little bit about electrocorticography and subdural electrodes, this was pioneered by Dr. Wilder Penfield and Dr. Herbert Jasper at the Montreal Neurological Institute in Montreal, in Canada, in the 1930s to 50s. This is called the North American approach. And here you see Dr. Penfield and here Dr. Jasper, and they're working together, demonstrating the ideas of teamwork around epilepsy and the workup, as well as offering epilepsy surgery. They introduced methods for awake craniotomy, the ability to record from the surface of the brain using special electrocorticography tools. And ultimately, they were able to map interictal events and use this to help guide surgical epilepsy resections. This was very much a two-dimensional perspective, recording from the surface of the brain, but it was very important and made great strides towards our understanding of seizures and performing successful resections. These are some of the historical devices that Dr. Penfield used. You see the type of ball and probe device, which they would apply and rest very gently on the brain itself and record. And Dr. Penfield was excellent at taking careful observations and notes and outlines about each of his cases. And not only were they recording, again, the interictal activity, but also mapping out the homunculus and eloquent regions of the brain as well. And this gave way to the modern concept of the subdural grid, as you see it here. And of course, this approach requires large craniotomies, wide openings, opening the dura to permit the placement of these arrays of subdural grids. We can implant them on the surface, the convexity, on the basal surfaces, as you see in these images, in the interhemispheric fissure. And there are different arrays or configurations of using small subdural strips and so on. Great care must be taken to protect the large draining veins, of course, the arteries and the eloquent tissues shown here. And in this way, it could be performed at the time of surgery, as electrocorticography often is, which can help guide the resection of an epileptogenic focus, or alternatively, with a hinge craniotomy, closing the flap, the patient can be left in the epilepsy monitoring unit to record for several days or a few weeks afterwards and allow for testing of eloquent function as well. And then moving ahead, we talk a little bit about stereo electroencephalography, and this is the European or the French approach. And this was pioneered by Jean Bacot, shown on the left, and Jean Telerac in the 1960s at the Sainte-Anne Hospital in Paris. And where they were different in their approach is that they looked at epilepsy as a disorder of networks. And Dr. Telerac had developed the Telerac frame, shown here, which allowed for very careful orthogonal stereotactic implantation of electrodes into the brain. And this was not a shotgun approach. Rather, they were guided by a very distinct methodology combining knowledge of the patient's anatomy, the electrophysiology, and the clinical workup, the semiology as well. And again, keeping in mind the concept of epilepsy as a network disorder, they sought to implant the brain in 3 dimensions with these careful electrodes that could record activity not only over time, but also in space, which they called the spatiotemporal EEG. Dr. Telerac is famous for many other contributions to society as well. One of the most notable was, and I present this to show, to highlight how the stereotactic neurosurgeon viewed other problems of the day. During the Second World War, in his spare time, he would explore the tunnels and the catacombs under Paris. And you see where the access sites would lead him to different tunnels or different networks of tunnels, and he would explore them and eventually was able to connect them and make a map. And this map he gave to the Allies when they liberated Paris from the Nazis in the Second World War. And I show it just to give you an idea of the man and his mindset in terms of how he approached epilepsy as well, in a similar fashion in terms of networks and developing access points, which are the electrodes that they would implant to record from the brain. Dr. Telerac's publications took a long time to make it into North America, largely because they were published in French. And so this is the first atlas. He developed the Atlas of Stereotactic Anatomy, where he developed cadaveric-based studies and introduced the Telerac frame and the Telerac Grid as a referential system. And I'll talk about that on one of the next slides. And then he combined his methods with the neurologist, Dr. Banco, to introduce this book on stereo EEG for epilepsy. And then one of their colleagues who studied under them, Dr. Zikla, introduced angiography to further refine the implantation of these careful electrodes into the brain. This is a slide dedicated to explaining the Telerac Grid. Dr. Telerac used pneumoencephalograms, and the anterior commissure shown here and the posterior commissure were easily identifiable on these scans. And he drew a line straight through them, which we call the ACPC line. And this was done to divide the thalamus from the subthalamic nuclei. And with the vertical lines applied at the anterior commissure in perpendicular fashion, as well as a posterior vertical line at the posterior commissure, we now see the beginning, the emergence of a referential coordinate system that Dr. Telerac liked very much because it could be applied to a brain of any size or shape without losing the proportional aspect for his implantations. So the anterior commissure is shown here on the sagittal view, and you see the posterior commissure here right at the tectal plate, just rostral to the cerebral aqueduct. And the anterior commissure is shown in this coronal section here as a band of white matter connecting the 2 temporal lobes. And here are some historical images showing Dr. Telerac with the frame, the patient on the table with the frame applied, the grid array that would sit at the side of the patient's head through which he would pass the needles, or the aiguille, as he called them. And down below, you have the cadaveric studies highlighting the development of this frame and grid system. And one of the first images taken with the implantation now on the cadaveric specimen. And this slide is just dedicated to show to our colleagues that it's not simply a matter of putting electrodes into the brain, but also taking great care in doing so. These are Dr. Zikla's anatomical images showing the brain with the vascularity preserved. And here in the background, you see the grid array again from Dr. Telerac. And you see the concept of the referential grid on the surface of the brain and taking great care to avoid the blood vessels there. These are some illustrations from Dr. Olivier's book at the Montreal Neurological Institute, showing a more orthogonal style of implantation, which continues the French concept, and we adhere to that as well here at the Cleveland Clinic. This image could be refined a little bit. You see again some orthogonal placements. We tried not to go through the crown of the gyri. The trajectories of these electrodes should pass in more orthogonal fashion, parallel to one another as best as able, but also to capture as much of the gray matter and the deeper parts of the sulci as possible. This was performed, of course, with the Telerac frame. Others have gone on to introduce other Cartesian coordinate systems or the Lexel frame as shown down here on the bottom left. And nowadays, this is performed with robotic stereotactic navigation as well, which has made for a very accurate, very safe, and fast implantation procedure. We use the robotic stereotactic apparatus that you see here, the assistant, but there's also the Renishaw device as well out on the market, and they are all equally good. In terms of indications for stereo EEG, I was very fortunate even 10 years ago as a fellow at the Cleveland Clinic to contribute in a small way to this literature, but this has exploded now, and there are many more indications for SEG. But keeping it simple, we use it for performing a very nice three-dimensional sampling of epileptiform activity. Secondly, for patients with non-lesional MRI, it can be very useful. Targeting deeper structures, part of complex networks, such as the mesial temporal lobe, the cingulate gyrus, the insula, the orbital frontal region, particularly the posterior orbital frontal region, and finally, the subtle focal cortical dysplasias that may be seen at the depths of sulci, where it's very difficult to place a grid. In patients who have failed invasive studies using grids, SEG has opened up a large opportunity to treat patients who were previously missed. And so this is now a good indication as well. And finally, in patients with multifocal seizure onsets and in performing bihemispheric explorations, SEG can be very helpful, very useful. Our surgical workflow consists of these images effectively, and I'll walk you through them, and I have some video. This is the implantation map, and at the patient management conference, the neurologists and the neurosurgeons and other team members will work together to recognize a hypothesis and an implantation strategy, and we will discuss the targets to implant. And from there, the neurosurgeon will program the robotic system. This is what the platform looks like, with an array of electrodes, each with a depth and an entry site, and therefore a trajectory. And this is where we can visualize vascular imaging, including an MRI with double contrast or a CT angiogram, and plan accordingly to protect the blood vessels there. In the bottom left, we see the robotic limb now comes into position and locks in place, and the surgeon works through the small port to make some holes with the drill, to pass a few set of tools to open the dura, and finally implant the electrodes. And the electrodes are held in place with bolts, as you see here in the bottom right. There are betadine strips wrapped around these for the antiseptic properties, but also for serving as a scaffold. As this material dries, it can actually help support the bolts even more, particularly in young patients, children, for example, or patients with very thin bone where the bolt might be a little bit mobile. This is an image showcasing some of the tools that we have to open the hole for the electrode. So drills, small probes that can open the dura, the bolt itself that is implanted. We use a small tract maker to open the trajectory, and finally the electrode itself, which is secured. This is a video here highlighting the workflow in the operating room. So what you see here is, in this case, the robotic device. This is from several years ago, and we have preoperatively programmed it. It takes about 4 hours, 2 to 4 hours to make a careful plan. And in the operating room, we're able, therefore, to expedite the workflow by just driving from one trajectory to the next. The surgeon drills through the port, and you can see that happening now. So the scalp incision and the bone is drilled through. We use the robotic limb as a stop to the depth, and the bolt is placed. And now what you see is a very careful, we've already opened the dura, and now we're placing the tract maker. It's a small, delicate tool which serves as a stylet. And this is really the last stop where the surgeon can palpate for any blood vessels that might be in the way before committing to the placement of an electrode. And you will see that very soon. It's very delicate, and this is where the tactile sense, if I feel a blood vessel, for example, if you're not able to mobilize around it, then you abort the implantation at that location. And once that is safely made, however, we're now at the point where we will pass an electrode. There are various companies, all of them have their benefits and, of course, some disadvantages. And with these electrodes in place, we're able to pass them to a pre-measured depth and then lock the cap to hold them in position. We often will, conventionally, we will always perform some testing, about 20 minutes of recording in surgery to make sure that everything is working before we leave the operating room. So here we have, just get the laser pointer, the postoperative images. These are the photographs taken with the electrodes so that we can reference them during the study interpretation afterwards. With the bedded-in strips, we take X-rays at surgery to look for, first of all, any deviation in the electrodes. An expanding hematoma will deflect them, for example. You see here that there's a very nice orthogonal strategy to this implantation. A few electrodes are actually crossing the midline, and we can do this in the orbital frontal region or in the anterior aspect of the cingulate gyrus, just underneath the falx. And that avoids, therefore, passing a whole new electrode from the other side. And once this is confirmed, the patient is taken for a CT scan shortly after surgery. And this is what this looks like, where we can see the location of the electrode contacts themselves. One can get quite fancy and generate these 3D images where we can see the implantation and where the electrodes pass in reference to the skull and the cranial cavity. But more importantly, below here, you see the Curie-generated software images, which show the placement of these electrodes and where they pass through the different anatomical structures. And this facilitates our interpretation of the SEG. A brief word about the targets, entries, and trajectories. We adhere to the French School of Epileptology, and we use very similar nomenclature. Apostrophes denote the left side versus the right side, as in these two examples of different patients with either a frontal hypothesis or more of a perisylvian temporal hypothesis. And again, apostrophes denote the left side. On the right, the images are actually those from Dr. Telerac's manuscript on SEG. And we attempt to achieve an orthogonal implantation as best as we can. This is an image that made it to the cover of Brain earlier this year in February, but it's taken from Dr. Telerac's archives, showing how patients would pass the time in surgery. It shows a very nice depiction, though, of the grid array and the electrodes that are implanted in this patient. But typically, patients will spend 1 to 2 weeks on the ward now in the modern era, where we can record, we can perform testing and stimulation studies as well. And ultimately, the electrodes are then removed. And we do this very carefully to ensure that there is no broken piece left behind or broken electrode as well. Now, the utility of stereo EEG is not only in capturing, of course, the target region for treatment, number one here, identifying an epileptogenic zone, perhaps in a deep target somewhere in the orbital frontal cortex or in the mesial temporal lobe. But also at the time of surgery, it can be very helpful for the surgeon. It can assist with surface localization. So what we mean by that is, if, for example, in this image on the right, you see the tattoo of the SEG electrodes in the cortical surface itself. You see our close proximity to blood vessels as well. And this can help the surgeon. And knowing, for example, that on this navigation study where we've recreated the SEG implantation for this patient, this is somebody who is undergoing a resection of the mesial frontal lobe. It was important to know that the anterior 2 electrodes were active in the Eggdol onset zone, but the posterior electrode was silent. And therefore, we knew that we had a posterior limit and, in fact, a boundary that helped guide the resection here on the posterior aspect. So surface localization is facilitated with SEG, as are the surgical boundaries. But also, additionally, I'll play this video one more time just to show that we were able to recreate these electrode implantations using depth electrodes and, in fact, capture intraoperative electrocorticography during surgery. And with a grid and some other electrodes applied, we were able to monitor these recordings and watch them go silent through and at the completion of the resection itself, which was very interesting and can be used to help guide surgery as well. Additionally, stereo EEG has opened up the capacity to perform radiofrequency ablation, which we now do here at the Cleveland Clinic as well. This is a patient who underwent this implantation, and the T' and U' electrodes are in the superior temporal gyrus, and U' captures the Heschel's gyrus, the anterior transverse temporal gyrus. And that's shown here in this red circle, where you could see that this upper bank of the sulcus was found to be a little bit abnormal. And so we took the patient to the operating room, applied a generator, and performed a small lesion along the length of that electrode at the hot spots, the contacts that were involved in capturing the seizure activity, the more lateral part. And this was done more of a diagnostic application towards identifying what would happen to the rest of the network. And we continued recording a few more days and took the electrodes out. And in this case, the patient was rendered seizure-free. It has been almost 7 months now, perhaps 8 months, and hasn't had any seizures. And so we're holding off with the resection for the time being until possibly the seizures recur. But it does highlight the fact that radiofrequency ablation can be facilitated and can now play a role in the diagnostic workup of SEG as well. Now, come back to a simple case where SEG played a role. This is a 36-year-old adult patient, right-handed, who had seizure onset at a very early age in childhood, at the age of 7. And at that time, the seizures were characterized by a dialeptic spell with behavioral arrest. It was occurring several times per day, and they were well managed on carbamazepine. And eventually, the family stopped the medication after several years because the seizures had stopped, seemingly. By the age of 16, however, they recurred, and the patient was put back on medication and went through several trials of medication shown below. And by the mid-20s, the seizures had increased. And at this point, the patient was now on Keppra or levetiracetam, carbamazepine, and clobazam. There was a family history of seizures as well. And at the bottom, I just want to reference Dr. Bulasio, our neurophysiologist at the Cleveland Clinic, for this excellent case and for his great help with all of our SEG studies. Now, the seizure semiology in this patient was very interesting. It was characterized by a sound which sounded like waves or almost a sensation. And this was the aura, and noises in reference to this would become louder or softer, and then the room would begin to spin. And it always progressed from there. And therefore, the patient would have a decreased awareness, looking around with some abnormal tongue movements within the mouth, and the lips would often turn blue. And then the head could turn left or right, and often would conclude with an elevation of the right arm. Post-ictally, the patient was confused, and this was occurring frequently every 2 to 3 days. On EEG, for the sake of time, I won't go through the details, but suffice it to say that the ictal and interictal EEG patterns were consistent with right temporal activation. They all seem to localize to the right temporal region. An outside hospital, OSH stands for outside hospital, 3 Tesla MRI was reported as non-lesional. And when we looked back with our excellent neuroradiologist here, Dr. Ruggeri, he thought that perhaps the superior temporal gyrus had a little bit of blurring, very subtle, very difficult really to tell from the other side, but in retrospect looks a little bit questionable perhaps. We conducted what's called a VBM study, or a voxel-based morphometry assessment, and this was consistent again with this region in the right superior temporal gyrus. That looked a little bit interesting. And there was further corroboration from the ictal SPECT, showing here some activation in the right superior temporal gyrus, the right temporal lobe, as well as the orbital frontal region. And a PET scan showing on the coronal image here some decreased metabolism in the right temporal lobe and in the basal temporal region as well. A MEG study was non-contributory with multiple scattered dipoles on both hemispheres. And therefore, because there was not a great concordance of data, and with the subtle imaging that we saw, the very almost non-lesional MRI, the decision was made to proceed with stereo EEG. Amongst other things, you see here a perisylvian implantation, with the hypothesis being either the temporal pole or the temporal perisylvian region or the superior temporal gyrus itself, but also to assess whether to include the mesial structures or not in a possible resection. So you see here the electrodes themselves with the lettering that we have here, and this is the photograph. I have just a few representative slides to show the interictal and the ictal activity that was recorded. You see, firstly, with SEG signals that there is no muscle artifact. It's very clean. It's a little bit easier to interpret. And there was a fair amount of spiking activity along the superior temporal gyrus at these two electrodes, J and T, particularly in the lateral contact. So the larger numbers, you see it's quiet on the mesial side, but at J, the lateral ones showed some activation early on, and T as well. And this is J electrode goes through the temporal pole and the superior temporal gyrus there at the planum polare and into the orbital frontal region. And T goes through the planum polare, that smooth part of the superior temporal gyrus in front of Heschel's gyrus. And Heschel's gyrus was activated a little bit later. And you see here a zoomed in view with some blue arrows showing that's just a little bit more detail, J and T in comparison to the other electrodes. And this is summarized in this image here. So this was the intraictal. Now, additionally, later on, the amygdala and the hippocampus were also showing some of this activity as well, and that's represented laterally by the dotted line. But here you see again a very careful circling of the two most involved regions in the lateral temporal neocortex along the superior temporal gyrus. Now, the Eggdol activity showed this even further, and classic seizures for this patient were collected with that wavy aura again at the beginning. And you see that J and T were the first electrodes to be involved more laterally again, with a later involvement at the U electrode site in Heschel's gyrus. So this tells us that it wasn't, in fact, the aura that was the first aspect. The aura followed the seizure onset at the J and T electrodes, in fact. And what you see later on in these recordings is that A and B, later on the amygdala and the hippocampus became involved as well, but much later. Just a zoomed in view showing how this looks when you come in closer. This is another example showing a very similar seizure onset. Again, this time showing J and T activation, and much later you see the amygdala and the hippocampus itself getting involved as well. More in these electrodes down here. Now, at the same time as recording seizures, we can also perform stimulation and assess and identify eloquent tissue. Now, SEG is not as good as grids at mapping eloquent regions, but it can identify some eloquent regions. And what we found in the stimulation part of the study, again, thanks to Dr. Bulasio, we found that activation of T4-5 at that contact site induced the classical typical seizure for this patient. And right away, you see that the J and T prime electrodes fire, and later on, the amygdala and the hippocampus come into the picture as well. So this was very good, strong concordance and good evidence that we were in the right area here. So this is the summary of the Eggdol activity. And based on that, a resection was proposed at our patient management conference, and the patient went on to have a resection of the temporal pole, including the superior temporal gyrus, effectively the lateral temporal neocortex, sparing the mesial structures. And you see that shown here in this resection. And it went on to become seizure-free and has been seizure-free now for nearly 3 going on 4 years, possibly by the end of this year. So the technology, therefore, for in vivo recordings from the human brain has improved dramatically. We can also couple this method with an improved understanding of structural connectivity. We can look at diffusion tensor imaging, for example, in the left, or we can perform through the stereo G electrodes what are called cortical-cortical evoked potentials, where if you stimulate one contact, you develop a structural map of what might be connected to that space. We have smaller electrodes. We can perform this with robotic guidance. Obviously, these are minimally invasive, and they're 3D implantations. And therefore, when the epileptogenic region can be found and disrupted, then surgery is very effective, either through resection or a disconnection or a laser ablation, for example. But significant challenges remain. One, finding the target remains difficult, particularly in non-lesional cases. How do we interpolate between the data, somewhere where we are not currently implanted, or how do we extrapolate beyond when we're wondering, is there activity beyond the site that we are recording from? And there are answers to this in mathematics and neuroengineering. And this is also going to refine how we stimulate for neuromodulation. We're in an era now where there are devices that can deliver stimulation, but we still don't know how to do this well. The where to stimulate, the what, with what, and how and when, the timing, the spatial and temporal aspect of it remains to be determined. We know that we need multi-site signals to study epilepsy. It's becoming clearer and clearer that this is a disorder of network dynamics, but we need to be able to develop further the ability to interpret SEG data and stimulate. We are now in an era of responsive neurostimulation, for example, through the NeuroPace device, which offers some ability to stimulate at the surface or in the depths, but this technology has a long way to go still. And I say that because VNS, RNS, and DBS all still have a very machine type of signal that is being delivered. This is the a square wave pulse. This is what the RNS delivers, is a biphasic pulse, in fact. But we need smarter ways to manipulate brain dynamics, looking at the dynamical connectivity, perhaps tweaking or modulating some mathematical or statistical property to disrupt synchronization and correct homeostatically the brain's dynamics back to a normal rhythm. And this will be, of course, tailored to each individual patient. This is what the future looks like. We have learned a lot about artificial intelligence, and the emergence of applications for epilepsy surgery is astonishing, even at this early stage in the last few years. There are reports in the literature now on selecting patients or predicting outcomes or identifying epileptogenic targets, using AI to guide the SEG implantation, and I'll show a slide on that. And finally, what I was talking about, using the analytics now to guide neuromodulation and perhaps performing a personalized tailoring of epilepsy surgery. So a brief review of the literature over the most recent years shows how people are looking at high-frequency oscillations with machine learning, or interpolating the electrode sampling, what to do with a grid when you fail to capture part of the grid, for example. Can we assess what's going on there using the environment around it? And finally, reverse engineering high-frequency oscillations using deep learning methods. And ultimately, what we will find with time is, as we collect this data better and better, as we are doing now, we will begin to look at the data and extract some features, pass them through some machine or deep learning algorithms, and develop a dynamical profile for the patient and decide surgical planning based on that. Here's a brief slide to show how robotics and AI have changed SEG planning. As we perform SEG, we need to take into account the fact that there are blood vessels in the way, there can be collisions between the electrodes, and so on. And this takes time, and the planning can take hours. We were very fortunate to publish on the emergence of robotics in neurosurgery over the years, and a lot has changed since this paper came out as well, but largely guided by the need to implant stereo EEG electrodes and perform DBS in the epilepsy and functional arena, amongst other procedures. And this was a nice paper with many accuracies of these systems and the complication rates and so on. And here's a nice paper that highlights how AI has played a role. And these authors developed a multiple trajectory planning algorithm using artificial intelligence. And they modified all of their plans and trajectories and were able to generate excellent maps of up to 12 electrodes in less than 1 minute, all automated, versus the 2 to 3 hours of conventional manual planning. So there's a lot that technology can offer. But for now, suffice it to say that we need to work with colleagues in engineering and mathematics and computer science, physiology and genetics, and start to bring some of this big data, as we call it, together. And perhaps one day we will see what this diagram shows, that the collection of data, pre-processing, the study of EEG, extracting some feature or dynamical or statistical property that we can learn from using machine learning and deliver a stimulus to abort a seizure, or perhaps at least forecast seizures more effectively. So in conclusion, epilepsy surgery continues to evolve. With these methods, we're able to record intracranial signals from the brain. We talked about grids, ECOG, and SEG. We have improved technologies now that are shaping how we deliver treatment based on these findings. There's been an evolution of neuroengineering and mathematical and computer science methods, now data science methods using artificial intelligence and machine learning, which will revolutionize how we study these signals. And finally, the last point is that we do require multidisciplinary collaboration to develop and advance this field, and bringing into the fold the ideas of AI, machine learning, robotics, closed loop implantables, and so on. And I would just like to conclude with one nice quote by Dr. Penfield, who was sort of one of the first to capture this idea of dynamics and what's happening in the brain. And he said, "The brain is the organ of destiny. It holds within its humming mechanism secrets that will determine the future of the human race." Very optimistic quote. And that leaves us some food for thought. And thank you very much to the organizers again for inviting me. I'm very grateful to share in this time and learning so much from this meeting. And I'd love to take any questions. Thank you.